See, so my topic is how we should decide, like for the treatment of EGFR mutation NSCLC patients, what factors we should consider for a patient, and like obviously this is age old debate whether we should go ahead for sequencing from second generation to third generation in EGFR mutation NSCLC advanced and metastatic patients, or we should start with third generation only. So are there any factors to decide this? So first of all, as we all know that lung cancer is the most common cancer incidence and mortality wise, if we see all sexes and in males also. So there are around 2.94 million new cases per year and around 1.8 million mortality per year according to global data 2018. So in both sexes combined, lung cancer is the most commonly diagnosed cancer. It accounts for around 11.6% of total cases, and it is the leading cause of cancer death. Around 18% of the total cancer deaths are due to lung cancer per year. So to further diving into deep, just to consider like what parameters which we should see in a trial, in a study, which determine the choice of first-line treatment in advanced EGFR mutation NSCLC. So whether out of these statistical analysis, PFS, OS, overall response rates, so out of which is more important to us. So it may depends on like tumor burden and patient symptoms, and whether brain mets were there or not at presentation, or those brain mets patients are symptomatic for those or not. So if patient is symptomatic and we need good response, early response upfront, so this is also a factor. And most of all, safety and toxicity profile, quality of life, and patients who are receiving subsequent therapy upon progression. So this last point is very important to counter the argument for sequencing. So we are going to discuss about these different parameters in future in this presentation. So if we see, there are three generations. We all know three generations of EGFR TKI. First generation are gefitinib and erlotinib. Second generation are afatinib and dacofatinib. Third generation is osimertinib. So although cross trial comparisons are not allowed, should not be allowed, and but still for references, obviously head-to-head study are not available at present. So for reference, if we see median PFS in first generation TKIs are around 10 to 12 months. In second generation TKI, 11 to 15 months. So slightly better than first generation TKI, but not much. But in third generation TKI, landmark trial Flora, they have shown that PFS is around 19 months. So if we compare from gefitinib, it is around double, almost double from the first generation TKI. So osimertinib have provided unprecedented improvement in the PFS in Flora study. So if we see regarding this PFS in Lung-7 study, they have taken brain mets patient, but those patients are asymptomatic, and around 16% patients were with brain mets at presentation. In Archer study, it is very surprising, but still they have excluded all brain mets patients. So in Flora study, brain mets patients have been taken even more than Lung study, that there are around 20% patients with brain mets at present. Should be stable. If symptomatic, then after radiation, otherwise asymptomatic patients. So beside this point, what this Kaplan-Meier plots, I want to emphasize that with Lung-7 study, in Lung-7 study with afatinib, so afatinib versus gefitinib, they have compared, and both the graphs are crossing each other, like separate from each other after a gap of around 1 year. So till 1 year, there is no difference if we use first generation or second generation TKI. In Archer study, this gap is after 6 months. This separation is after 6 months. But in Flora study, if we use third generation TKI in those patients, so this benefit of the third generation TKI, if compared to the first generation TKI, is from the beginning only. So there is immediate separation of the curves with the initiation of the treatment. So early separation of PFS curves is shown by osimertinib only, Otherwise, with afatinib, 12 months later separation occurs. In dacomatinib, 6 months later separation occurs. So this is regarding PFS. So just we should not go for just for numbers. We should see what is the exact mechanism and how these curves are separating each other and when. Then next is overall response rate. In Lung 7 study, overall response rate with afatinib were 70%. With first generation TKI afatinib, it was 56%. So median duration of response is better. Obviously, it is 10.1 months, and so duration of response is 12.7 months. So it is better, obviously, in the second generation TKI is first if compared with the first generation TKI afatinib. Similarly, in dacomatinib study, overall response rate is 75% versus 72% only with afatinib. So not much difference. Median duration of response is 14.8 months versus 8.3 months. So statistically, this also significant. In FLORA study, overall response rate is 80%. So if we just want to compare from afatinib or dacomatinib, it is 70 versus 75 versus 80%. So best overall response rate with the third generation TKI. And even 7% patients have shown complete response, and then most of the patients have shown partial response. Duration of response is around 17.2 months. At landmark of 12 months, 1 year, 64% patients are still showing response, and at the landmark of 1.5 years, 50% patients still showing response. So osimertinib has shown highest overall response rate and median duration of response if we compare these three studies. Next point is overall survival. So if we see final analysis and with the long follow-up, overall survival with the osimertinib arm is 38.6 months versus comparative EGFR TKI, that is first generation TKI, it is 31.8 months. So hazard ratio is 0.79 and p-value is statistically significant. So we can clearly see here that both the graphs of these Kaplan-Meier plots are separating from the beginning only and remain separated till the last, and even after 3 years of follow-up, 50% patients on the osimertinib arm are still ongoing and showing responses and taking treatment. So median overall survival is more than 3 years. So this was unprecedented before this study and haven't seen earlier in these NSCLC and advanced NSCLC patients. Osimertinib patients were more likely to be alive at 2 and 3 year landmarks, and first time an EGFR TKI has translated PFS to a significant OS benefit. So this is very important point. In other studies, either Lung 7 study or dacomatinib study, they haven't quoted any OS benefit with those drugs. There was no OS benefit with those drugs, although there is some confusion of hierarchical statistical system or in dacomatinib study, but still numerically they have shown that there is PFS improvement, but there is no OS improvement with the second generation TKI. But in third generation TKI, FLORA study, OS benefit was there, and that was statistically significant. So afatinib failed to improve OS versus afatinib in Lung 7 study. In Archer study, although numerically there may be OS benefit, but because of this hierarchical gatekeeping procedure, which was used for hypothesis testing. So what was that? They have quoted earlier that during the protocol submission that if PFS improvement will be statistically significant, then they will go to see overall response rate. And if that is statistically significant, then only they will go for OS analysis. Because overall response rate was not statistically significant, hence formal statistical hypothesis testing for overall survival was not concluded in this study. So phase 3 Archer 1050 trial regarding this dacomatinib use, they have already excluded patients with brain mets. So as I've told you that in NSCLC patients, in advanced NSCLC patients, it is 20 to 25% chances that patient have brain mets. So those patients in this study have been excluded, although it reported a numerical improvement in overall survival of 34.1 months of dacomatinib arm compared to 26.8 in afatinib arm. But because of the hierarchical statistical design, they haven't done analysis of OS. So 28% of the patients were still receiving osimertinib at 3 years, and these 28% patients were still alive and taking drug regularly without much side effect, with good quality of life. And if we compare with the another comparator TKI, first generation TKI, then this number is only 9%. So osimertinib demonstrated a superior systemic PFS benefit regardless of the CNS disease status. So they have done subgroup analysis, and what they have done, analyzed that if in around 20% patients were with upfront brain mets. So if patient with brain mets or without brain mets, whether in difference of PFS with the use of osimertinib, so they have shown that hazard ratio in both the subgroup is 0.47 or 0.46, same. P-value is statistically significant. So whether brain mets are there or not upfront, so osimertinib have shown good responses and PFS improvement. So CNS progression event occurred in 17% versus in 6% versus 15% patient receiving osimertinib versus standard care. So there is term CNS PFS, and with osimertinib they have analyzed and reported that median CNS PFS have not been reported with not reached with osimertinib, versus in first generation TKI it is 13.9 months. So this also is statistically significant difference. CNS PFS was statistically significant better with osimertinib if you compare with the comparator first generation TKI. So whether the significant CNS response have been seen first time with the first line osimertinib or in other TKIs also. So in this busy slide, what I want to emphasize that intracranial or CNS response have not been assessed in LUX-Lung 7 and 3 or 6 studies, and in documentary study, Archer study, they haven't taken those patients. Patients with brain mets were excluded from Archer study. So out of all these 3 studies, Flora was the one in which they have analyzed this CNS PFS and have shown that this is statistically significant. What about safety profile? So this is very important point, especially regarding dacometinib. So grade 3-4 adverse event with dacometinib were reported in 63%. So this is a huge number. Like around 2/3 patients will show grade 3-4 side effect. It's not about any grade, it is grade 3-4 side effect. So in those patients, either drug dose reduction or delay or discontinuation have been seen. So if any grade or like more than 3 grade side effect with afatinib arm in LUX-Lung 7 study was 31%, and osimertinib arm it was the least. Only 18% patients in Flora study have shown grade 3-4 side effect. If we see side effect profile, so almost similar side effect profile, same EGFR related side effect, acneiform rashes, stomatitis, diarrhea, fatigue, but least numbers in Flora study. So with afatinib, skin side effect were 9%, with dacometinib it was 14%, with osimertinib it is less than 1% only. And on the other hand, diarrhea 13 versus 8 versus 2% only. So as I've told, because of these significant grade 3-4 side effect in both Archer study and LUX-Lung 7 study, significant dose reductions of these TKIs have been done. In LUX-Lung 7 study, adverse event leading to dose reduction were more frequent in patient receiving afatinib, that is 41% versus 1% only. In Archer study, more dose reduction have been seen in dacometinib group, that is 66% versus 8%. On the other hand, in the Flora study, frequency of dose reduction were similar in both the arms, osimertinib versus standard of first generation TKI, 4 versus 5%. So we can clearly see here that in osimertinib arm in Flora study, most of the patients have tolerated drug very well. There are very less grade 3-4 side effect, and there is no need to decrease the dose. What about quality of life? So quality of life, obviously, if there are more side effects, then quality of life also hampered. So in Flora study, global quality of life was improved from baseline in both osimertinib and EGFR TKI group, and there is no much difference with the third generation TKI. So now coming to this slide, this is very important slide, and this is mainly against the motion that we should use sequencing. Like so what I want to say that if we use sequencing, like if we use first generation followed by second generation or third generation, or start with second generation followed by third generation, then what is the problem? So problem is that 1/3 of all EGFR mutation patients, if we treat with first generation or second generation TKI, only 1/3 patient will receive second line osimertinib only if patient is eligible for that. So to explain that numerically, let's say example, we have 10 patients and we have started with either first or second generation TKI. So what happens on progression? Only 70%, 70 to 75% patients will be eligible for second line treatment. Otherwise, rest patients either die due to the disease progression and will not be benefited with the second line osimertinib, or just receive palliative care. And in most of those patients, even T790M mutation testing will not be held. So these 7 patients out of 10 patients, they are eligible for T790M test results, but only 60% patients out of initial 10 patients will go on to for this testing, 790M mutation testing, and that is maybe due to lack of tissue biopsy. Patient may not be willing, patient may not be having significant tissue for biopsy, and there may be some problem with the standardization of the sample. There may be some false negative testing. So from the 10 patient, now remaining 6 patients only, and those patients, if we do T790 mutation, 50% patient will show mutation positivity, rest will show negativity. So as I've told you that only 1/3 patient, so 3 out of 10 patients will be treated with second line osimertinib. Only 3 patients will be eligible for second line osimertinib. So rest 7 patients will not be benefited with the third generation TKI if we have used that earlier in the first line only. So 7 out of 10 patients who start on first generation, second generation TKI will not be able to receive osimertinib in the second line, and it is not possible to predict which patient will develop T790M mutation resistance. There are no soft or any other parameters based on which we can say that this patient will be T790M mutation positive more likely, or will get benefit from the second line osimertinib more likely. There are no such parameters. So on the basis of which approximately 1/3 of the patient will not have access to second line treatment, and this is the main problem with the sequencing. Although there is some real world evidence from the about the T790 mutation testing, if we have used afatinib earlier. So in a Japanese study, only 43% patients of treated with first line afatinib which have T790 mutation. In Taiwanese study, 48% patients who were re-biopsied have acquired T790 mutation. In other Taiwanese studies, 28 afatinib treated patients, T790 mutation have been identified in 32% patients. So real world scenario, even this is even less than this 50% value. So as I told you that in whatsoever patient we are going to do this.
Hello. Hello.
So Pooja,
Yes, sir.
like due to some technical error, my computer have been switched off. So if you can share slides from your side,
Sure, sir.
from where I left.
Sir, we don't have your slides, sir.
I'm just sending.
Okay.
I've sent.
Sir, just give me 2 minutes. Huh?
Yeah. Yes. So, sorry for inconvenience. So, just next slide, please. I have already discussed about this slide. Next slide, please. This also I have already discussed. So, regarding the sequencing of EGFR TKI, so if we start with prior generation EGFR TKI, either first generation or second generation, then if we want to treat those patients on the development of EGFR T790 mutation with third generation TKI, so this is not optimal clinical care because there are few minor points which we should consider, which should decide. So we are not smart enough to figure out which patient will get EGFR T790 mutation. So out of those 10 patients, earlier, like around 2 patients who have not survived after first generation TKI, or those 3 patients in which we are unable to do biopsy. Out of those 5 patients, maybe there are few patients who are already T790 mutation positive, but because of that, first or second generation TKI have not been useful, but still we haven't given appropriate drug to those patients. That was a problem. So not everyone will be well enough to receive additional treatment. Only 30% patients will receive subsequent therapy. So there is problem of tissue or liquid biopsies and standardization because we sit in RGCI. So it is very simple and easy for us just to go ahead with liquid biopsy if no tissue biopsy is available, but it's not the case for every institute. Osimertinib associated with significant survival benefit even in the first line. So as the dictum say that we should send best better upfront for the opening. So why not here? We should use first best drug in the first line only. Why we should hide this drug for the later line? So there is no explanation for that. So next slide, please. So uncontrollable factors in sequencing are toxicity of drugs. So there is more toxicity in the first and second generation TKI if we compare with the third generation TKI. So occurrence of T790 mutation, we don't know in which patient this T790 mutation will be developing on the course of treatment and or not. Which site disease will progress, whether we will be available able to do biopsy from that site or not, whether uh, liquid biopsy available in our institution or not. So some concurrent mobility and patient choice are also some uncontrollable factors in sequencing if we choose for that. Next slide, please. Even NCCN guidelines, if we see, so although NCCN pleases everyone, so they have given all the TKIs, rather first generation, second generation, third generation TKI as a first line option, and all are category 1 option. But still, if we see here, so they have given osimertinib preferred choice out of all TKIs. Next slide, please. So to summarize, osimertinib is the only EGFR TKI which has demonstrated a clinically and statistically significant improvement in the overall survival. This is the most important point regarding this FLORA study. This is the first drug in which OS survival have been quoted. The median OS benefit of greater than 3 years, which has not been seen earlier with any other drug in these advanced NSCLC patients. So it has sets a new benchmark for osimertinib and provide a window for opportunity for the management of these patients with stage 4 with sensitizing mutation, and reaffirm that it's important as a first-line therapy. FLORA is the first time an EGFR TKI has translated PFS into OS benefit. Nearly 30% of the patients remained on osimertinib even after 3 years. Osimertinib is the only drug which can be given in patients with brain mets and with T790 mutation. So as we have shown, discussed earlier, in tecometinib study, there was no brain mets patient in afatinib study, they have taken brain mets patients, but they haven't analyzed any brain PFS. So we don't know whether those patients have been benefited with afatinib or not. Osimertinib is the safest and least toxic drug among all the available options, and sequencing can be considered best strategy. Can't be considered best strategy because 70% patient who may be eligible for osimertinib but will not get osimertinib in the second line because of the sequencing. So these data confirm that osimertinib should be the first line standard of care in metastatic EGFR mutation NSCLC patients. Next slide, please. So with this, thank you. I will conclude my slide. Any query from my attendees or my seniors? So you may ask. If no question further,